So I do have one disclosure. I'm not going to try to sell you anything related to this slide, but just so you're aware. What I'm going to ask you to do in the next 40 minutes is kind of change your perspective. And I would assume that this is a very easy case for many of us to handle in the reading room. What we see here, is a very typical popcorn-like lesion, left periatrial white matter. There's susceptibility. This is a cavernoma that is bled. And that would be the typical way that we would interpret the report for this patient. But the problem is that the anatomy, the location of this lesion is actually very important to the referring physician, the neurosurgeon who may be dealing with this case. And so what we see if we did fMRI is we'd see that it's actually immediately, medial to the Wernicke's area, the receptive language area. We know that the arcuate fasciculus, the dominant white matter language pathway, is basically abutting the dorsal, superior, and inferior margins of this cavernoma. So this is a very difficult lesion to resect. The neurosurgeon may actually need to know where the central sulcus is. And the point of this slide is that I'm not going to try to teach you how to do fMRI or tractography, although I am going to give you a 30-second Oprah Winfrey explanation of it. But the idea is that there is a lot of really important anatomy here, and I think that I can use my experience doing brain mapping at NYU to teach you some of the sort of easier ways to communicate more specifically where lesions are. And I think that's very helpful for your referring physicians. It'll improve the value of your reports. Some of this anatomy I would assume that you will know. This is, of course, veiled, the front half. There's no way that I could teach you all the neuroanatomy that may be important in a 40-minute lecture. Today I just skied the far right side. I stayed in the blues and the greens, and there's no way that I could teach you this map or the equivalent on this lecture. What I'm going to try to do is sort of show you where the big lifts are, the safest ways to get back to the hotel. And I'm going to sort of talk to you in sort of three different areas. We're going to talk about cortical anatomy, sulcal anatomy that's useful. I'll show you some functional MRI, but again, the expectation is not that you will learn fMRI, but at least learn some of the locations that are really important to the referring physicians. And then we'll talk about what I think are the key white matter pathways that you should probably be able to kind of guess where they're going to be, even when you're reading just a CT or an MR. And to help this along, I've again, to be cute, I've sort of color-coded the anatomy that I'm going to show you. So I would assume many of you will know some of the green dots. Some of the blue you may also know. There's a few black diamonds here. Personally, I'm never going to ski a black diamond in my lifetime. And many of you may not be neuroradiology trained and not be interested in the black diamonds, but it might give you some interesting trivia to tell your friends about. But I think the blue areas are areas that may actually be very...
All right, we'll go ahead and get started. And we're going to discuss the posterolateral corner of the knee. We're going to start off with clinical drivers, look at function and mechanism of injury, as always, really emphasizing the anatomy and MR imaging appearance of pathology in the setting of the posterolateral corner injury, and then look at several examples of injury so that we're really clear on, what these different patterns look like. So as we think about posterolateral instability and clinical drivers, the classification as we look at it from the orthopedic literature really focuses on three structures: the popliteus, the lateral collateral ligament, the capsule as well, and then we're going to also include a few other dynamic stabilizers. Dissections here, and you can see as you're looking at this dissected image, you're seeing several of the structures we're going to talk about. Fibular collateral ligament shown here, popliteus, and then you're looking here in the unstable situation where that tibia kind of translates anteriorly, and then we're having additional motion and rotation at that tibia. So 72% of injuries to the posterolateral corner are not diagnosed on clinical examination, and that results in a delay in this diagnosis for up to 30 months. And when these posterolateral corner injuries go undetected, the problem here is that it leads to further instability, micro to macro instability. And part of the reason that these things aren't detected initially clinically because they occur in combination with other injuries. And so they stabilize the knee in the vast majority of cases for a week, 2 weeks, 3 weeks, and the clinical exam becomes very, very challenging. And I'll show you exactly how they do that clinical examination and why. You'll see immediately why it's so challenging. So the take-home point here is that injury to that posterolateral corner, if undetected in the setting of other injuries, will lead to instability and degenerative changes down the road. So when we think about the mechanism of injury, shown here in these rugby players, here you're seeing the varus force along that medial aspect of the knee. So the varus with external rotation is really the classic mechanism of injury, and it's rare for the posterolateral corner to be isolated with respect to its injury. So it often occurs with a hyperextension injury or rotational injury with ACL, but rarely in isolation all by itself. So as we consider the direct, that blow right to the medial aspect of the articulation with varus force, there can be many other mechanisms. And as you look at extreme sporting events, professional sports in general, weird things happen when you start to get injured.
All right, so let's talk a little bit about where AI fits into the spine imaging sphere. We'll do a little bit of another introduction on AI in healthcare and society, hopefully mention some points that we didn't mention when I gave my AI and image reconstruction talk. But then we're going to talk about tools that are really available that you probably don't even know about that could make a difference on your spine imaging. For those of you who are wondering, what that video is, those are my 3 kittens, cervical, thoracic, and lumbar spine. All right, so we know what AI is. It's a tool that essentially lets computers do tasks that are typically associated with human intelligence. You can see what's going on in the healthcare industry more and more every year. This chart only goes to 2019. I think you know where it's been going since then. And probably the most compelling sign that this is here to stay is that it's the big OEMs, Siemens, GE, Philips, that are amongst the top patent applicants. So this is not only in healthcare, but it's a mainstay in imaging, as you can see. I showed you this chart before, but between big data analytics, which is really a machine learning thing, one of the things about AI is that, what humans find hard, which is finding patterns in huge amounts of data, computers find easy, but humans find easy, like recognizing your mom, it's a little bit harder. It's much harder for AI to do. So, even though we'll show you some great data of what AI can do, that there are definite limits to what AI can do. There's still no judgment, despite the amazing things that generative AI can do. So between what they call AI and big data, it's really the biggest technology to impact healthcare over the last who knows how many decades. I did tell you that things are moving along pretty well with deep learning. You can already see that computers have fewer errors than humans do at image recognition tasks, and the same thing applies for speech recognition tasks. And we covered this, for the most part in our other presentation. It's here for completeness on this particular presentation. But as you know, all the fuss these days is about generative AI, right? And you can see the type of funding that we're getting with generative AI. Probably something like $25 billion, put to it over the last year. And tons of investment. And overall, artificial intelligence investment has gone up quite a bit, but a lot of that, or a disproportionate amount of that, has gone to generative AI. You can see this is from the McKinsey report. This is traditional AI, and you can see just from the advent of generative AI, and frankly, a lot of things we said just 3-4 years ago, AI will never be able to do this, AI is never going to be able to do that, it will never threaten people with high-level positions. You can see what's actually happening. There's a lot of surprise happening. You can see there was a significant economic impact,